All right, welcome back, medical ethics friends. Today we're going to be looking at a most interesting and difficult subject known as healthcare and healthcare as a right. And how do we understand it? And do we have it? And what does that mean? And why is there so much disagreement around it? But just to recap, we just got done looking at John Rawls and Robert Nozick and kind of what's the just and proper role of government in a just society, right? And as you recall, I'm sure you recall, uh, John Rawls was the big advocate for central planning, for the role of governments to correct the inequalities of nature, right? Like there are natural inequalities and there are social inequalities. Natural inequalities are some people are born taller and more handsome, more talented, more athletic, stronger, better singer. Some people are born shorter, smaller, uglier, with less intellectual firepower than others. And that's a natural inequality. That's just the way it is, right? In every society, there are inequalities. Those are natural. Both Rawls and Nozick say, all right, yeah, that's the way it is. We can't change that. Where they differ is Nozick says it is not the government to try to correct those inequalities. It's the government's job to largely stay out of the way of people doing business together, and it's the government's job to protect people and their property and restore it if it gets stolen or coerced or threatened, right? John Rawls says no, it is the job of the government to correct those social inequalities where they can find them. That's literally, and he says it's the first principle. Justice is the first principle of social institutions. So, how do they feel about universal health care? Yay! Yay, universal health care. And so today, one of the things I want us to think about is what kind of good is health care? Is it similar to other goods like cars, clothes, or toys, or is it a different sort of good? If so, how is it different from most goods? Do we have a right to health care? What constitutes an acceptable level of health care? So in our textbooks, I'm just going to read some from the beginning of part 2. I will leave it here for now. I assign this, and this is just sort of the summary of each of the sections, because we're not going to be able to get to them all. And they're looking at the passing of the Affordable Health Care Act, the individual mandate, and looking at how do we understand healthcare. Because if you recall, John Rawls thought that we should use taxation, right? We should take some of people's profit and use it to provide goods and services, right? Like roads, like schools, which would be a right to public education, and that we are justified in taking some people's wealth to provide these goods and services. And so the question is healthcare of the same sort of thing as that? I'm going to read here from the bottom of 148, top of 149. What kind of a good is health? Is healthcare a right? What is the relationship between health and healthcare, given that individual health status is profoundly influenced by many factors of a person's social and economic environment? Most people get access to a variety of essential goods, including food and shelter, by participating in the market and spending their own money. What, if anything, makes healthcare sufficiently special that it should be provided through taxation and government-mandated insurance coverage? So there's a couple really interesting questions here. One, what is the relationship between health and healthcare? Just because I have great healthcare does not mean I have great health. And a lot of people who have great health do not have healthcare, right? And what you will find on one of the later articles on why America does not have the highest, what's the title of it? It's basically why America doesn't have the best healthcare in the world. And the author looks at the reasons or the correlation between health and healthcare and determines that really putting more money into healthcare does not, why the United States is not number one in health. Nailed it. Right. So that's in there. And it really raises the question of like, okay, we all want to live in a healthy society with largely healthy people. And are we going to get healthier people if we produce an increase in healthcare? Many of you think, of course it is. But there's a good argument in that one that really we'd be better off spending that money not increasing healthcare for everybody, but putting it into restoring other socioeconomic imbalances in that society. So that's an interesting thought. Another interesting point here is, all right, healthcare is important, but is it important enough that we should take people's property against their will to provide it to others? Right? Like, do we generally think that shelter and food is important, right, and essential? But do we require other people to pay for our house and our groceries? No, even though we can't really survive without shelter or food, right? We don't generally think that other people should be forced to pay for it. But if we think that healthcare is something that everyone should be taxed and provided for, even if you think that those people maybe neglect their health and exploit the system, and right, these like leechers or second handers and all the talk that accompanies with that. So those are some interesting questions. But I want us to look at, and we're going to look more at how we understand healthcare as a right and the distinction between positive and negative rights, or welfare rights and liberty rights. Will help hopefully parse this out. But reading from, I guess I can find, where's it? Do, 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 do. So I used to assign the President's Commission an ethical framework for access to healthcare because it was pretty formative and it's referenced a lot. It's in here, it's long, so I'm just having us read the excerpt of it and trying to kind of condense down the questions to get our thinking oriented. So it looks at whether social inequalities in healthcare are unjust or merely unfortunate. Right? Some people are just don't have the same access to healthcare as affluent people. Is that just unfortunate? I'm like, oh, bummer. Like it's a bummer. You don't have as big a TV as I do, right? Or is it unjust? Is it like a violation of a person's basic rights, right? And so, give you my ugly, ugly mug here to stare at. And so, according to the Commission, health problems can significantly affect the range of social opportunities that are open to an individual. Moreover, many health problems are caused by factors that are beyond the control of the individuals they infect. Like, is everybody responsible for the health problems they have? No. Lots of it's genetic, lots of it's predetermined or inclined towards based on your genetics. However, is a lot of it up to your choices, right? Whether you exercise and have a good, healthy inner and outer well-being and have a good diet and et cetera, et cetera. Yeah, there's a lot of it that comes down to your choices. So it's kind of, environmental, kind of genetic. And to what extent do we hold people responsible for that? And to what extent do we think in the realm of John Rawls and say, hey, you don't know who, if you hadn't been born yet, you might be born in a body that's plagued with illness and disabilities and additional hindrances to the quality of life that you want, right? Is that your fault? Should you be burdened with it and taxed with it when you already have the disadvantage to begin with? There's a good argument to say that no. John Rawls is right. It is the role of social institutions to try to correct those natural inequalities to the extent possible. Moreover, or as a result, the Commission argues that health problems and the restrictions on opportunity that they produce are often undeserved. They argue further that the factors that cause health problems are often difficult to predict and to prevent, that they are widely but unevenly distributed in society, and that their effects on individuals are often costly to ameliorate. As a result, the Commission concludes that the free market alone cannot be counted on to meet these crucial needs, and that society therefore has an obligation to meet them. Providing access to healthcare represents the natural mechanism through which society should discharge this obligation. The Commission views healthcare as being different from other consumer goods and that it is crucially related to one's level of well-being, helping ward off pain, suffering, and premature death. And this is the kicker, everyone pay attention. Like education, healthcare is necessary to achieve equal opportunity in society. And healthcare is freighted with interpersonal significance. As the philosopher Michael Walzer puts it, failure to obtain needed healthcare in our society is not merely dangerous, it is also degrading, signaling a lack of full citizenship. Ooh, wow, big claims. But the real kicker here, I think the linchpin to really focus on, is that the claim made by the President's Commission is that failure to be provided with adequate healthcare access constitutes a violation of your equal protection and equal opportunity under the laws. So they're trying to root it to a fundamental right based on our government, our Constitution, our Bill of Rights, that you cannot be denied equal protection, equal opportunity under the law. Make sense? The Commission insists, however, that this social obligation is not unlimited. It must be discharged with an eye to the costs and burdens to society in meeting it. Excuse me. Moreover, the fact that society is morally obligated to provide some care does not mean that everyone is entitled to an equal amount of health care or to health care of equal quality. In other words, not all inequalities in access to healthcare constitute inequities. So long as everyone is guaranteed access to an acceptable level, or as others put it, to a decent level of healthcare, society will have lived up to its moral obligation. So one of the things I really want us to think about, because we're going to look at a case study here, is what constitutes a basic or adequate access to healthcare, right? What share of healthcare costs should individuals be expected to bear, and what responsibility do they have to use health resources prudently? Is it society's responsibility to ensure that every person receives care or services of as high quality and as great extent as any other individual? Keeping me honest, does it require that everyone share opportunities to receive all available care or care of any possible benefit? If not, what level of care is enough? So they go through things, so it's is basic access to care just making sure that you're not dying? Or should the taxpayer be required to pay for maybe experimental high treatment or high cost treatments like the high dose chemotherapy and autologous bone marrow transplant, right? There's a case in here where you can look at a woman who, these treatments cost hundreds of thousands of dollars, right? Should taxpayers be required to pay for that? Or what's fair for a 60-year-old who breaks their leg and goes in to the hospital? What's adequate basic access to healthcare? Is it giving them a crutch and being like, hey, this is just you now, now you have a limp? Or should the taxpayer be required to pay for leg surgery, right? And a little bit further on, there's an article by Norman Daniels. He writes a lot of articles. And he kind of tries to draw the distinction that we can figure out what's a basic adequate access to healthcare by what restores us to what he calls a normal opportunity range of functioning, right? And this is a distinction between health-related needs and health-related wants, right? So he says, you shouldn't have healthcare pay for nose jobs or tummy tucks or liposuction, right? But if you have a chronic illness or you have a car crash, and broken bones and bleeding, then obviously you're restored. That's either life repairing or life restoring or life sustaining. It's not enhancing, right? The idea that growth hormones or body augmentation. Now, fertility drugs is an interesting one, but if we were in class, I would have us make a list of what we thought was a healthcare need and what we thought was a health-related desire, right? Where's LASIK surgery, or where do braces fall or teeth whitening or all these things which seem like it gets in the gray zone. And what we find is that it's not as clear a distinction between what is restoring and what's a need and what's a desire. But to kind of push the issue, I'm going to pivot us over to uh, a case study, and then we will be rocking and rolling, and I'll give us a little break. So, what constitutes an adequate access to healthcare? Here we have a tough case study, and you really hear a lot about, or a lot of people grumbling why they don't want universal health care, because they would have to pay for people who make bad choices and abuse resources and just kind of are like neglectful and taking. And this is one of these things where we want to keep our heart, people. We want to have empathy and grow our compassion and kindness for others. And yeah, we want to hold people responsible for their choices, but there's a lot of things that happen in life that are not in your control. And you might not want to pay for the homeless of the world, not want to care for them, and think that their problems aren't yours. But as I would say, this pandemic is showing us is that, like, no, we are not that far apart. And if their quality of health and their lack of access to healthcare really exacerbates, that's going to directly affect your quality of health and your access to healthcare. And so, anyway, long winded, let's see what we got here. On a bittery, cold January evening in New York City, Mr. McCaffrey, a 63-year-old homeless man well known to the hospital, came into the emergency room complaining of generalized weakness, intense pain on coughing, and pain suggestive of a heart attack. Dr. Edwards, a first-year resident, interviewed Mr. McCaffrey, consulted with the attending physician, and subsequently ordered a number of tests. All tests were negative, suggesting that Mr. McCaffrey did not have a heart attack. Dr. Edwards began to suspect that her patient was malingering. She spoke with Mr. McCaffrey, who confessed that he was hungry and did not want to endure the cold weather outside. It was clear that Mr. McCaffrey was in suboptimal health because of his homelessness and age, and it was quite possible that if the hospital were to put him on the street, he might return as a result of a heart attack or with pneumonia. On the other hand, using the emergency room for non-medical purposes drains resource, time, patient rooms, caregiver energy. Dr. Edwards wondered how far she should go to check out Mr. McCaffrey's complaint each time he showed up. What should the treatment plan be for this returning patient? So, got a homeless person coming in, obviously can't pay for his services. To what extent is the hospital, have a duty, right? A duty of care, a duty of to exert reasonable caution, right? Commentary. I know Mr. McCaffrey. He has bipolar disease and routinely visits my emergency department. After his wife died, he lost his job, started drinking again, and now lives behind a store in an alley. When he's not in jail for illegal lodging or public intoxication, he's at detox or in our emergency department. When paramedics call to announce his arrival, someone invariably says, when are they going to do something about Mr. McCaffrey? The emergency department staff at our sister hospital knows him just as well as we do. Usually, one of his friends calls 911 if he mentions shortness of breath or chest pain. He often spends 20 minutes in an acute care bed awaiting lab results, x-rays, a CT scan, and a meal. When he's sober enough to walk to the bathroom, he usually wants to leave. Every visit represents at least $1,000 in uncompensated care, and those visits now total more than 50 just for Mr. McCaffrey. Social workers refer to him as non-compliant. He explains that he simply hates shelters because they're dangerous and his backpack is always getting stolen. Last winter, he was admitted for pneumonia and had a non-CT segment elevation myocardial infarction, non-STEMI. He did well on mood stabilizers until discharge, but never followed up with a physician. It's no surprise that staff feel frustrated and even angry whenever he arrives. And now, on this icy cold night, a young resident named Dr. Edwards is assigned to Mr. McCaffrey, who has come in complaining of chest pains. Since the passage of the Emergency Management Medical Treatment and Active Labor Act, EMTALA, in 1986. It's important to know EMTALA. Emergency departments in the United States have progressively become medical care providers of last resort for millions of individuals. Medical departments operate around the clock and are an essential component of the public health safety net. Unfortunately, the resources to meet the needs of all emergency department patients are rarely available, particularly on nights, weekends, and holidays. The case of Mr. McCaffrey illustrates how emergency physicians can find themselves with an empty toolbox and must compromise to meet their responsibilities, patients and themselves. So EMTALA, the Emergency Management Medical Treatment and Active Labor Act, basically, one of the authors in our textbook makes the case that it is already codifying a basic right to healthcare in our country. That literally emergency rooms cannot turn away a patient in a life-threatening condition due to failure to pay. Right? So just because they're homeless, if they literally are about to have a cardiac arrest, a heart attack, you have to treat them. Yeah. And so that's really interesting because in 1985, the year after I was born, we had passed into law saying no, emergency rooms have a duty to save people's lives if they have any signs that they're going to die, right? Regardless of the cost. Now, personally, I think this is a good baseline, right? I think John Rawls would appreciate it. I think Robert Nozick, while he wouldn't support it, recognizes it's a fair baseline, Now, the question is, what constitutes adequate access to healthcare? Mr. McCaffrey's evaluation should follow the same procedure. Emergency physicians often work backwards from worst to best case scenarios, particularly when evaluating patients with complaints like chest pain. Your first exchange must convey a sense of caring, even if they're a frequent flyer. Hello, Mr. McCaffrey. My name is Dr. Edwards. How can I help you today? They should reflect genuine concern if she is to convince him of any future recommendations. You must also avoid bias from prior references to frequent flyer that may appear in his medical record. What is different tonight that made you come to the emergency room? Goes through the standard workup for someone with cardiac arrest signs. After she excludes this, she recognizes his unfortunate circumstances, and given that it is midnight, neither she nor he wants to see him return to the icy streets. He may have survived the last 10 years on those streets, but his chronic homelessness places him at increased risk for premature death. Tonight, he simply has acute bronchitis, but he could once again develop bacterial pneumonia. The real problem is that a combination of homelessness, poverty, and untreated mental health has trapped him in a revolving door that opens only to the streets, jail, detox, and the emergency department. Individuals like Mr. McCaffrey, who are being cared for in U.S. emergency departments every day, is relatively small, but these frequent flyer users of services consume enormous acute care resources without appreciable gain. Is that true, you say? Well, over the past 5 years, Boston Healthcare for the Homeless program identified 18,000 emergency visits by 119 people. So someone do the math. How many visits per 119? Over 4 years, 529 chronically homeless alcoholics amassed 3,300 ER visits, 650 hospital admissions, and healthcare bills totaling $17 million. Yeah, 530 people racked up $17 million. Is that fair? Is that just? Would the opposite be better or worse? In Washington, during 2002, 198 of the 130,000 participating adults generated 9,000 emergency visits and consumed 19% of all Medicaid expenditures. Someone who's good at math can just break those numbers down and let those stats detonate in their head. But, and this is the really interesting thing, because currently, you might say, actually, if we had better universal health care for these people, they wouldn't be going to the ER. The ER is not the place for most of these people to get treated. They need appointments, that it's consuming vast resources and beds that are needed for people with, in accidents that are bleeding out severely, right? That, if we actually put more money into better things, we would save in the long run. Fortunately, some communities are testing novel approaches for these patients. San Diego Serial Inebriate program provides housing and treatment in lieu of custody to chronically homeless people who are alcoholics. In 1 year, they reduced episodic emergency department visits, improved rates of sobriety, and produced cost savings of more than $70,000 a month. Are you kidding me? Another program, when patients were connected with housing, income benefits, health insurance, and a primary care home, a 61% decrease in ER visits and a 62% decrease in inpatient days occurred over 2 years. Dang, that's awesome. However, Dr. Edwards has no such program at her disposal. She needs a utilitarian short-term solution. If he can't walk, it requires admission. If he can walk, his needs of this night are essentially shelter and food. And basically, providing her attendant physician is in agreement, she should notify hospital security and the nursing staff of her plan, and she should explain to Mr. McCaffrey that she believes the best plan among 11 is set, basically like let him stay down in the hospital lobby, right? At least for one night, Dr. Edwards can feel satisfied she has provided Mr. McCaffrey with safety. She can take less comfort from the realization this scenario is likely to be repeated. Better options would be to refer him to additional services. And so, this is a really long video. I'm going to wrap it up. But did Mr. McCaffrey receive an adequate access to health care? And if not, if you think he should have, how much more care should he have, right? And should you force it on him if he doesn't want it? Because he doesn't want to go to shelters. He wants to, not be there, be somewhere else. So here we have our first real look at, where the rubber meets the road. Obviously, we can't give everyone full access to any health-related need or want that they have. But what's the core? They kept him alive. They decided he wasn't going to die that night. Right? Go forth and be free. So we'll see what you guys think. Let me know, and see you next time.